So, when I look back on the last, actually probably more like 15 years that we've been doing this, and I really appreciate everybody's comments, and I've learned so much over the last 15 years, especially from everybody in that room. Dr. Pimenta, Bill Taylor, Neil, Juan and I remember when we started this course about 10 years ago, we really were just understanding what the potentials were for lateral. Here's my conflicts. I have many of them, and in particular, the Seattle Science Foundation. I'm really proud of all the work that we've done there, and I'm super conflicted with lateral spine surgery, as you guys will see. And I wanted to put up a picture of my X-rays. This is my left leg um, that I injured skiing, and actually, thanks to Jens Chapman, I had some of the best surgeons in Seattle at Harborview fix me, and they did a very nice lateral approach on my leg. Um, and and thank God, one of my best friends is Jens Chapman, who knows everybody in Seattle and around the world. And when I called him from the ER in Big Sky, and I told him what happened, he knew exactly who I needed to see and who needed to do my surgery. And what's so cool about this is, and being a neurosurgeon, I don't know anything about tibial plateau fractures, but I learned so much in the last month. And it's amazing what the orthopedic surgeons have done, and especially at Harborview in Seattle. We're so lucky. Sig Hansen, Steve Bernershka, and Sean Norick, and Daphne Beingessner, and actually Jens was a big part of that whole team, and especially on the spine side. But what's interesting, and being a neurosurgeon, I don't know if you guys can see this, but this is actually called a kickstand screw. This is a stainless steel plate, and this is my tibia, and I had a depressed, it's called a Schatzker type 2. So anyways, I've learned a ton. And
Old chubby guy is doing on a ski.
yeah,
Question.
exactly, Juan.
Yeah.
And again, going back to the whole reason why we're here is, when I graduated from residency at University of Virginia, I remember Dr. Jane, similar what Bill said earlier. He kept saying, "Look, Rod, you got to do something. You got to do something new and cool in spine." And I remember at the time, and I had heard both Dr. Pimenta and Dr. Taylor kind of doing this crazy approach to the lateral spine. And I spent a lot of time, unfortunately, over the last 15 years, I've spent a lot of time with Dr. Pimenta, and really having both Jens, who's one of the, I think, probably the greatest posterior deformity surgeons, who has really influenced and really pushed me to understand the lateral approach and be able to, because so much of what these cases and will present, you got to be able to tackle the spine in a different way. You can't always go posterior. And so when I started doing lateral, people weren't really doing it that much for tumor, trauma, and infection, and we really didn't understand the anatomy. And so fortunately, because of the fact that we again, just being at the Seattle Science Foundation, being in Seattle, you guys have seen the lab, we have access to cadavers. And I really started to study the anatomy. And I remember calling Dr. Jane, and also talking to Dr. Pimenta and Jens. And really, there was no good books. All the books we have are these old Netters and Gray's Anatomy. And again, fortunately, just because of where we are in Seattle, we have access. We have great fellows. These are some of our research fellows, so we're able to do a lot of anatomical studies over the last 15 years, and really understand what these relationships mean. And again, when you look at these old textbooks, they're it's similar to the brachial plexus. They kind of made these cartoon-like figures for people, for us to memorize, but it's not really what it looks like in the spine. And a lot of our fellows spend a lot of time. These are some early cadaveric 3D reconstructions of the plexus. And again, what I quickly came to understand and learn is that each person has really a unique plexus, and not one person has a similar plexus to another. And again, you can see this is Jens and his cousin, and even though they're related, they're very different. You can see, but they have some similarities. And the same is true, I think, for when you do anatomy and you start looking at the plexus, and then we started using, actually, this is very this was a long time ago, and it's very rudimentary, but we were trying to understand what these relationships were and how things look like on a fluoro. Because obviously when you're approaching the spine, you're not going to see the plexus. You're really only going to see the discs that are there. And again, as the years went by, we started to collect more and more data. Each year we had our fellows work on this huge project that we had going. And again, fortunately for me, I was surrounded by people that are way smarter than me. So this is a great picture of Keith Mayo, who's a godfather in hip and pelvis surgery and orthopedics. And Thomas Schildhauer is one of Jens's old fellows, and Cliff Pierre and Alex Monglitsky. And, what I learned is that, if you surround yourself with people that are smarter than you, you learn a lot more, and they contribute so much to your, understanding of like structures that we don't really have an understanding about. And the plexus was, for me, a really fascinating structure, because we really didn't understand that much about it. Again, I think having this exposure and having, like our research meetings every week, which Jens leads, and the fellows, and our relationship with Bochum and Thomas Schildhauer has really, I think, changed, our understanding of what these structures are and what they all mean. For example, here's a 3D reconstruction of the lumbar plexus, and you can see how complex it is. And it's it's way more complex than our previous rudimentary understanding that we had. And again, as you peel away the fibers of the psoas muscle, you can see how crazy the plexus is, and how, when you're thinking about, doing lateral surgery. I mean, to me, to this day, I'm still amazed that people don't have more injuries and have more complications. You can see it's like the LA freeway here. It's 405, the 10, they're all intersecting here. And here's another great 3D reconstruction that was done with one of our fellows with the psoas and the plexus. And again, the team here at SSF, we wouldn't be able to do this without all the courses and the intellectual giants that come through. There's a picture of Linda and Corey, and then Ben's in the lab here videotaping. You can see there's a picture of Juan in the lab as well. And then, Gary, who sets up the lab, and there's Alexis. It's unbelievable the amount of data, the amount of work that we did just in this one course, if you think about it, over the last 10 years, and how much I learned from everyone in this room. Again, for me, being able to do lateral spine surgery really has changed my practice, and we use it a lot for tumor, trauma, and deformity cases. And we're able to do a lot of these cases, and I'm going to go over some cases, do in a safe, reproducible manner. Here's a nice picture of my recent stay at Harborview. You can see my team, and there's Jens came and visited me. But here's a thoracolumbar case that we did, and again, Certainly you could do this, I think, all posteriorly, but what if you could go in laterally, get a very nice reconstruction, get a very nice large cage in, and decompress that canal, and maybe not have to go 2 levels above and 2 levels below, and save the patient from getting a huge incision. And you can see how posterior I was able to go to take out that bone fragment. And again, here's another case that I did. You can see this patient had osteoporosis and a compression burst fracture. I went in, took out the screws laterally and then, or posteriorly, then went laterally and did a corpectomy and then went back and staged it. Here's a tumor case that I did. Again, this was, you can see here that that's L4. And so retractor time, as Dr. Taylor mentioned earlier, is a big deal. And in a lot of these cases, I remember early on, I actually would go and find the plexus and try to go anterior to it. But you can see here for a tumor patient to be able to get, a large cage like this in and do a very good decompression can really change their outcome and their game. And Juan was very nice enough to share one of his, this is one of Juan's exposures that he recently did at Barrow. And you can see the difference between his exposure and my exposure. Mine is a lot smaller than his. But this is what, this is what we used to do for doing corpectomies. And you can see retractor placement is very important. So you have to get the retractor posteriorly when you're doing these corpectomies, and you have to understand, where the plexus is, where the femoral nerve is. And again, this is another tumor case. You can see here there's a huge epidural component, and I'm able to go in, and you can see the posterior wall is basically gone. And again, for these cancer patients, it's truly a game changer, because I can go in and put in percutaneous screws in the back, and things like wound healing and getting up out of bed and getting out of the hospital get significantly reduced. Here's another fracture, a tumor case that I went in laterally and was able to do a very short construct. And again, for my practice, let's say 10 years ago, we would have been doing a large anterior exposure, and the patient would have been in the hospital for a long time. Here's a case that Jens and I did. He went in posteriorly, and then I went in anteriorly. And you can see, I wanted to show this case particularly because you can see how far back you can put this retractor and how much of the bone you can take posteriorly when you're doing a lateral approach. And here's the post-op films. And you can see here that again, just because I think this was a Mets case, we're able to get most of the tumor and get a very nice reconstruction there. This is another patient, again, doesn't have great bone quality, has metastasis. You can see here, and we did the same thing, went in from posteriorly, and then I went in laterally and did a corpectomy. Here's a recent case that I did, and actually I was able to do most of this through again percutaneous, and then the bone quality wasn't great, and unfortunately this patient had pretty significant metastasis, and so don't want to do a large construct, want to try to avoid getting into the sacrum and the pelvis. So and you can see the amount of central and epidural tumor that's there. And so we did a very, very small construct. And again, a lot of these tumor cases, you're dealing with very poor bone. So it's nice to be able to not have to go more than 1 or 2 levels above and try to, for example, in this patient, I was trying to avoid going into L5 and a sacrum. And here's her x-rays. She's 6 months out, and you can see, just because of the size of the implant that you can place, there's very little subsidence, and the patient is doing great. This is another tumor case that we did. And I don't know if you can see this very well, but this is a picture of Jens Chapman as a resident. I don't know if you guys knew this at all, but Jens actually is a very talented guy and used to play in a rock and roll band on the weekends and when he was a resident at UT Southwestern. I don't know how he had the time to do all this, but and I think he actually was the lead singer and played guitar. And you can see he's got a little bit more hair back then than he does today. Again, another tumor case. You can see here most of the vertebral body of L3 is involved, and a pretty significant amount of epidural compression. What if you could do the same thing? What if we could just do a posterior reconstruction and then come in and do a lateral? And that's what we ended up doing. This is Gary Hawley, who is the lab director at SSF and has been with us for more than 10 years and really helped, for me, was kind of the backbone of trying to get a lot of these cadavers and trying to get a lot of these cadaver studies on the weekends and at night. So you got to have a great team, and you got to have someone like Gary Hawley. Here's an interesting case because again, as I think Bill and Luis have talked about, and what I've learned is this is actually, I'm showing the neuromonitoring probe, and I actually will go and try to find and stimulate and find the femoral nerve and then try to dock anterior to it. And as soon as the retractor goes down, I look at the clock because retraction time is key. And so unlike, I think a lot of times when you're just doing lateral, you don't always necessarily want to find the nerve, but when I'm doing corpectomies, I actually want to know exactly where that femoral nerve is and how far posterior I can go. And you can see again, just from going lateral, how much lordosis you can get. And even with the posterior fixation in, you can actually still lordose the spine because, as you can see here, there's not much ALL left. Here's a very cool case that Jens and I did. It actually was a trauma case, and you can see here there was significant pseudoarthrosis. The posterior wall had not been removed, and you can see it was done from a lateral. Actually, it was a shark bite, but then they did an MIS approach from the back, and you can see there's pretty significant subsidence, and I was able to go in and cut the cage and then remove it, and this is what these images show. And then you can see how in the end plates where the cage previously had gone, I actually put a cage that was much larger that was there and provide very good end plate coverage, and was able to actually, we were able to only just do that one corpectomy. But you can see how powerful doing a lateral approach is. And again, she had previously had a shark bite incision, and we actually went posterior to it, and the incision was like very tiny, and she did great post-op. And then just putting a plug in for our book, this was 10, 12 years worth of work, and a lot of our fellows, and a lot of what I learned from, this course and all the great minds that have come through SSF contributed to this. So I've learned a lot. I continue to learn, and hopefully we're going to be able to do this for 10 more years, and appreciate being involved and working with you guys. Thanks again.
Thank you, Rod. Okay, guys, we're really behind. It's actually disgusting.
Can I ask one question?
Yeah.
Is the microphone working or not?
No. This is disgusting how behind we are.
Yeah. So I know. So sorry that we're late. So Rod, not only do they good, orthopedic surgery at Harborview, they gave you good drugs also, and we have a censorship program in the future for your slide collection. It's all photoshopped AI. No, but all joking aside, so that last slide that you showed of the lumbar plexus has this round orangish thing running around it called the psoas, PSOAS. So now the orthopedic realm that you brought up is really pertinent here, and that is, what happens to that muscle after you've done those procedures there? Is that just hamburger? Do we really need a psoas? I mean, you've become a new fan of healthy muscles with your own legs. Do we need a psoas, or is that wasted? What's going on with that?
You know, that's an interesting question, and I do think that the muscles do play a huge role in it. And again, and I've seen, you know, there definitely is, I think there is some muscle atrophy and loss, you know, when you do these procedures and you don't stay in the planes, and you know, if you're not careful, I think you can definitely injure the muscle.
But like a 3-level, I mean, I want to recognize yours and Juan's, Luis's, Bill's enormous contributions to the field. Neil's, I mean, so many great people. So you've done amazing things, and I so rely on you just taking care of my anterior column needs. But for me, this is still one of those things that muscle gets shredded. And I don't know of any larger comparison studies. When I see my myriads of MIS patients who come to me for maximally invasive salvation, there's a routine thing that psoas is basically gone on post-op MRIs. So that's my one concern. So I appreciate your neurosurgical neurofocus, but now that you have an orthopedic focus also on muscle health, that's my next challenge to this team of great people and the next generation to kind of look at that a little bit more.
I mean, I definitely think the psoas muscle does get, you know, some trauma to it. But again, I think as we've evolved and learned, you know, I think when you stay within the fibers, you know, we're very careful. And Juan, I think you probably are the same. You know, my technique has evolved over the last 15 years pretty significantly. So, but it's definitely an issue.
Yeah. Okay, Rob, we're gonna keep going. This is a break time right now, so you guys go and grab something, but come back to the room right away because.